So let me just say thank you everyone for joining us to the first Polycon UK webinar that we're having after the Easter break. We're very happy for all of you to be here and to welcome you back. And we're extremely excited today to have Erika Deserranno with us. She'll talk about financial incentives in multi-layered organizations, an experiment in the public sector. This is joint work with Stefano Caria, Gianmarco, Leone, and Philipp Kastrau. Some of the authors may be in the chat, I'm honestly not sure. And before I hand over to Erika, I just want to remind you that our webinar takes place every 2 weeks on Mondays at 3 p.m. In 2 weeks, we'll actually have Arda Gitmes, who I think I've already seen among the participants. And as usual, you can find more information about upcoming list of speakers on our website. And please also visit and follow us on Twitter or subscribe to our YouTube channel. The format of the webinar is as follows. The webinar lasts for 60 minutes, and we request all attendees to please keep your microphones muted. If you have a question, just raise your hand or ask the question in the chat. We'll monitor the chat, and we can also call on you once you raised your hand. If we do so, then please unmute yourself and ask your question to Erika directly. Please note the seminar is recorded, and at the top of the hour, we will then finish the official part, turn off the recording, and you're all invited to stay on for a couple of minutes to chat more informally with Erika about her paper. And yeah, that's it. So thank you again, Erika, for accepting our invitation. I hand over to you and looking forward to it.
Thank you so much, Andres, for the introduction, and thanks for allowing me to present this paper. This is actually a paper we really need feedback on. We would hope to submit soon. So it's a great opportunity to present that to you guys. Unfortunately, my co-author couldn't be on the chat today, but just feel free to unmute and ask me any question. Okay, so let me start with the motivation. As all of you know, organizations are often divided in multiple hierarchical layers with workers at the bottom and workers at the top. And obviously, because of these multiple layers, typically the effort of workers in those different layers will all contribute to the production of final output. So all workers will really matter for the production of final output. And this is because lower tier workers will typically not be effective unless they have a good manager who motivates them. But at the same time, the effort of a good manager will not pay out unless they have motivated agents below them. So obviously, this raises the question of how should incentives be allocated across the different layers of an organization, the bottom versus the upper layer of the organization. And this is not a question, that we are the first to look into. There is a vast theoretical literature that has analyzed and looked into this topic. However, empirically, the evidence is scarce. Most of the evidence that exists on incentives typically focuses in one layer of the hierarchy. So there are, for instance, a number of papers, which you probably know, which look at the effect of incentivizing the bottom layer of the organization. Very often these are frontline workers or civil associates. And basically this paper look at what happens when you increase the incentive for this bottom layer on their own productivity. There are also papers who focus on the top layer. So basically this paper look at what happens if you incentivize managers, supervisors, CEOs on the productivity of those managers, the supervisors, and the CEOs. The goal of this paper is going to be to leverage a field experiment and a structural model to study the allocation of incentives across layers. So the key novelty here is to really start to think about incentivizing across different layers. And one of the key differences with the existing literature is that typically the existing literature has looked at the effect of incentive in one layer, holding incentive in the other layer constant. What we're going to look at is a context where by increasing the incentive in one layer, you basically automatically reduce the incentive in the other layer. I'll be more specific about that in a couple of slides. So the context is going to be one of a large public health organization in Sierra Leone, which is called the Community Health Program. And I'll give you tons of details of this program. At this point, what I would like you to know is that is that the program is organized into teams. Effectively, a team is a geographical area with 2 layers. There are going to be 7 to 10 frontline health workers who provide health visits in their community. So these are people who basically go to households in their community and provide basic health services. And then on top of these 7 to 10 frontline health workers, there is 1 supervisor whose role is to train and advise the health workers. Now, the experiment will take place in a total of 372 teams, effectively 372 different geographical areas, where we are going to introduce a new incentive scheme that rewards each unit of output produced. So basically here, for each health visit provided by a health worker, there is going to be a pot of money available in the team. The novelty of this paper is going to be to randomize who receives the money while holding the total team payout per visit fixed. We will have a treatment where all the money goes to the frontline worker, the health worker, a treatment where the money goes to the supervisor of the worker providing the service, and then a treatment where the money is going to be equally shared between the two. So basically, we're effectively going to compare treatments which are very steep, meaning you basically incentivize only 1 of the 2 workers, and another treatment which is effectively flat, where the incentive is going to be equally shared between the 2. And just to give you sort of a very, brief preview of the results, and I want to avoid giving away everything, but basically what we will find is that having flat incentive, that is sharing the incentive between the 2 layers, is going to outperform one-sided incentives where all the money goes either to frontline workers or to their supervisors. And note that this is the case even though in many contexts, actually one-sided incentives to frontline workers are used. In fact, one-sided incentive to frontline workers are in many development contexts the most common incentive scheme you find. Well, in our context, we find that shared incentive actually does better than one-sided incentive. And this is due to 2 common features of multi-layered organization. We're going to show that it's due to the presence of complementarity in worker and supervisor effort, which is going to make one-sided incentive ineffective. Basically, it's going to be inefficient here to give all the money to only 1 or the 2 layers. And then it's also going to be due to the presence of limited site payments, such that incentives stick where they hit. Basically, the piece rate will stick where it hits. This will sort of prevent cohesion bargaining. And in a way, it's going to be ineffective in our setting to give everything to the supervisor and tell the supervisor, redistribute the way you want, because of the presence of limited site payment and the presence of contractual frictions. And I'll come back to that later on. There are some alternative mechanisms for why shared incentive work better. One of them is aversion to pay inequality. There could also be a story of sharp discontinuity in the utility and the cost function. We will show that these alternative mechanisms are really unlikely to explain the result in our context. And then finally, I'll present very briefly the results from a structural model of service provision, which is sort of important here because it's going to allow us to do 2 things. First, it's going to allow us to identify what is the optimal incentive allocation in our setting. So here we have 3 treatments, but potentially one could have chosen from a different allocation than our 3 treatments. So the exercise here will really be one where we're going to try to estimate what's the optimal allocation out of all the possible allocation possible. And then we are going to use as our structural model to simulate the optimal allocation in organizations that are different from ours, that is, in organizations that have different effort complementarity and different contractual frictions. And we will show how the results differ if you're in organizations where effort complementarities are weaker than in our context or stronger. And this is going to be important to understand how to best allocate incentive across layers of an organizations, depending on different organization parameters.
Sorry, can I ask here a question related to the results? you do not have any sense of fairness that participants might have from shared incentives. Is that not on the picture at all for some reason, or?
So we have data on, not on fairness, we have data on job satisfaction. And one story you could have in mind is that the shared incentive is perceived as being more fair, or it can lead to some sort of positive reciprocity. We'll actually show you that this is not going to be the main mechanism happening here. Part of the reason, and I'll come back to this later, is that health workers are actually not aware of the incentive supervisors earn. But let me get back to that when I get to the context. But the short answer is that we have data on job satisfactions, but we will see that the treatment do not impact differentially job satisfaction.
Thanks.
Great. So let me just say a few things on the related literature very briefly. I don't want to spend hours on this, but basically, I think generally these papers, at least I view this paper as being related to two broad literatures. The first one is a very vast literature on incentive problems in hierarchical organizations. And this is a literature which is both theoretical and empirical. Now, I think most of this literature, and you probably know some of these papers that I'm citing here, these papers typically focus on how to minimize harmful collusion between supervisors who have informational advantage over the principal and workers. They typically do not focus on the enabling role of supervisors and on the implications of effort complementarity for the designs of incentives. The real goal of our paper here is going to be to shed light on how the structure of incentives can foster synergies in the organization. And so our goal is going to really be to focus on that complementarity across layers of the organizations. We are going to be less interested in thinking about harmful collusion. And in fact, we will, by design, we will eliminate any possible collusion in our setting. I'll explain you more how we do this in a second. The second literature, which is actually not on this slide, is obviously the literature on incentives, which I've discussed earlier. And then the third literature is the literature on contractual frictions and side payments. Now, I'll show you in a second that transfers across layers are going to be very limited in our context. Now, in terms of transfers and contractual frictions, there is a vast literature that has focused on contractual friction across firms, but there is much less done within the boundary of a firm or of an organization. What we're going to show is that within the boundary of our organizations, side payments are going to be very limited. So if you give incentives to one layer, very little of this incentive will be transferred to the other layer. And this is actually going to limit cohesion bargaining. And exactly because workers do not optimally redistribute them on themselves, we're going to show that making the organization decision, of how to allocate incentives is actually going to be a central decision. Obviously here, if people were redistributing incentive optimally, we wouldn't care how the organization allocate incentives in the first place, because agents would anyway achieve the optimal, they would achieve cohesion bargaining, and you would achieve the optimal anyway. Here we're going to show that transfer are limited, and so the organization decisions of how to allocate the incentive is going to be central and is going to impact organizational performance. Okay, so unless I have any questions here, what I'll do now is that I'll go and discuss about the context and the research design. And then I'll briefly talk about the model. I don't think I can do justice. The model is actually way better than what I have time to talk to you about here, but I have to be brief. And then I'll talk about the results and the mechanism, and I'll briefly go through the structural model as well. Okay, so the context is the context of the Community Health Worker Program. We focus on Sierra Leone, but you should know that this community health workers program are very popular worldwide. The program we are looking at is a program that was created by the Ministry of Health in 2017 in Sierra Leone, and it was created in the aftermath of the Ebola outbreak. Now, as many of the community health worker programs, the goal of this program is to increase access to health services in rural villages. It is organized into geographical areas, which are all located near a health facility, which is called technically a peripheral health unit. And this is an important dimension here, because actually our randomization will be done at that level, at the peripheral health unit level. So I'm going to refer to this as PHUs. You should think about each PHU as an area, a geographical area, where there is a health facility, and around it there is a catchment area of 7 to 10 villages, which have all one health worker per village and one supervisor to supervise the entire area. So basically we'll work in geographical areas. In each area there are 7 to 10 villages. Each village has a health worker and has one supervisor for the entire area. Now, health workers are here the bottom layer of the organization. They're the frontline workers. What they do is that they provide health service through household visits in their community. And this is very standard of community health worker programs. So effectively what they do is that they go and visit household. During those visits, they identify whether there is a pregnant woman, and then they follow up by providing pre- and postnatal checks. They accompany for delivery at the health facility. So they really have a role in terms of pre- and postnatal care. The other type of role they have is that they provide education on disease prevention, and they also treat basic diseases with some drugs, which they have access to. And finally, they refer to the health facility for further treatments, or when they don't have the drugs available. And I think what is important to understand is that these community health workers are not nurses. These are guys who receive like a small training, a 2 weeks training at the very beginning. They are hired locally, and typically they have no experience in health. And they actually very often, almost always, have a secondary job, which is typically farming in this context. So these are guys who are meant to be the link between the health facility and the village, but these are not health professionals. And so the role of the supervisor is really key here. The supervisor is going to have the role of training and advising the health workers in the geographical areas. What they do is that they first provide a general monthly training. And this is crucial because the supervisor is going to be the one providing the basic skill about health. Remember, the health workers have no previous experience in health. So all the skills they gain is basically through the supervisors. And they gain it through this monthly training, which is organized at typically in a location in the PHU, close to typically to the health facility, where the supervisors give advice about, information about health. But the supervisors, there's something else which is very important, and which I'll show you is very important later on, which is that they actually go in the field with health workers, and in the field, they accompany health workers on household visits, and during this visit, they supervise and they train the health workers. And this will turn out to be very important, and I'll show you this, because this is the moment where the supervisors can give personalized feedback to health workers while they actually provide the visit, but they can also help build trust in the community. I mean, you have to realize that this is a context where households are actually used to see the health worker as like a farmer. And suddenly these guys show up at their house and gives advice on health and maybe products on how to treat diseases. And so obviously it's important here that that household trusts and believe the health worker is a good worker and is legitimized to work. And to do that, supervisor present during the household visit is key. So basically having a supervisor who occasionally go on household visits really helps build trust towards those community health workers. Overall, what this is saying, Go ahead.
Sorry to interrupt. I think Ara has a question, and then I think I have a question.
Oh, I was waiting for you to finish the slide, but
No, I'm so sorry. Let me actually, I'm not sure why let me actually get your, because I have only one screen. Now I see. For some reason, I didn't see the video of the hands popping out. Do you mind maybe, because I don't see your hands, do you mind just maybe interrupting me if you have a questions? That might be easier.
We'll keep track of hands, don't worry too. Thank you.
Cool, thank you. Yes.
I have two questions, I think. So the first one is that, would you say then that, is there a quality dimension of the service that's being provided? So of course, the main concern is that are these people trading off quality versus quantity, given the incentive that you provide? Yeah,
so that's an important question. I'll spend some time on this. The short answer is that there won't be. Basically, we see an increase in quantity coupled with an increase in quality and no trade-off, but I'll get to that. I'll spend quite some time on this.
So the second one is that, so I understand based on what you said is that these health workers do not have the type of career concerns that they might have. Like, would you say that a typical health worker has no sort of dreams of continuing in this as a health worker?
So I don't think so. There are career concerns in a way here, because there is the possibility of progressing to becoming supervisor. Mm-hmm. Actually, supervisors typically are former health workers. So there is a career concern. It won't matter too much. In fact, I have another paper exactly on career concern and on promotions. In this setting, it won't necessarily matter too much. One thing which is important, and I think makes this setting, typical of the public sector, and this I need to specify, is that while there are career concerns, there is very limited firing. So definitely exits are minimal. So in a way you can progress, but if you do badly, you're very rarely fired. So in a way you don't have that threat, which could matter, obviously.
I have a question too. So what's the degree of interaction at the bottom layer? So can we really consider that like as a layer where people are colleagues and peers and they know each other? Because some of these villages are quite far apart.
Absolutely. So absolutely, they know each other because they get to see each other every month and they get this general training. Now, they only know each other within a PHU at the geographical area. And this is why we had to randomize at that level, which made obviously the experiment much larger because we had to randomize across geographical areas de facto. So you should think of health workers knowing each other within an area, but not knowing each other across areas. In fact, across areas, they never meet. They do meet within an area. In fact, it's just too far to meet. So there are going to be limited spillover across our treatments, but definitely within an area, there's tons of interactions.
Erika?
Yep.
Can I also ask a quick question? Like the idea to use incentives to create these synergies across hierarchies, to what extent is it specific to the setting where, in a sense, I think they're basically, these public health workers are trying to provide a benefit to the community? How should we think about sort of like a context in which they might have sort of like more adversarial relationships with the citizens they're trying to interact with? Like
they would have less.
Like more adversarial types of relationships, like a tax collector or something.
So I actually don't know whether it matters that much. I guess it does matter probably for the results on the quality. What I'll show you is that basically health workers in the shared incentive treatment do more visits. But it's not like this is traded off by going to a household and provide very short visits. So the fact that there is a reputation that they know people may imply that conditional on going to someone, they actually spend some time to this guys because it's actually rude to go and get out. So they do care about people. So it may have an effect in terms of the trade-off between quantity and quality. So in that sense, it may explain partially. Reputation may explain why we don't see such a trade-off, but beyond that, I'm not sure. I think the implication would be quite, would apply to just a context where you don't have any reputational concerns or any social ties in a way.
Thank you.
Okay, so anyway, this is just to say this is a context where definitely health workers' ability to work will require supervisors to train them and to legitimize their presence in the community. And so the success of the program will definitely require both health workers and supervisors' effort. And so this is definitely a context with effort complementarity. I'll quantify this in the structural model. It's going to be very hard to tell you whether whether effort complementarity in our setting is like stronger or weaker than in other settings, simply because there aren't actually many structural models that estimate effort complementarity in other settings. But because it's obviously going to differ from other settings, we'll end up showing you what is the optimal allocation in organizations that have a different effort complementarity than in our context. So this is basically where the experiment takes place in 6 different districts, and each green dot is a geographical area with 7 to 10 visits, with 7 to 10 villages around, and we randomize at the area level, because this is the level. This is, first of all, the level at which a supervisor, basically each area has one supervisor, and obviously to minimize spillovers across treatment. Now, across the entire country, actually in this map, across the entire country and before our experiments, the way health workers and supervisors were incentivized is that they were receiving a fixed wage, which, by the way, was very often late, as in many government programs. There were often very serious delays in payments. The monthly salary was equivalent to 150,000 leons for health workers and 250,000 leons for supervisor. And these are actually quite standard rates if you consider that these are part-time workers. In the paper, we compare this to the outside adoption. It's sort of in line. What we do in this paper is that we introduce a new incentive scheme, which is going to pay some money for each household visit provided by the health workers. And more specifically, each time a health worker provides a household visit, she's paid 25 cents. And I'll tell you how we measure this in a second. But the point is that we are going to put on the table 25 cents per household visit provided. But we're going to randomize who gets the money. So the total amount put on the table is the same across all the treatments, but who gets the money will differ. In what we're going to refer to as the worker incentive treatment, we are going to allocate the incentive entirely to the health worker. And this is going to be a random 1/4 of the geographical areas. In the supervisor incentive treatment, another 1/4 of the geographical area, the incentive is given entirely to the supervisor. So effectively, when a health worker provides a visit, it's the supervisor who gets the money. In the shared incentive treatment, it's going to be equally shared. And in the control group, there are going to be just no incentive. So here we are in a context where the recipient of the incentive varies across treatment, but the total payout per unit of output is held constant. So if we see any difference across treatment, it's not because we put more money per output paid, it's actually because we change who got the money. And this is sort of the difference with most of the literature.
Question, how many visits does a person do in a day?
So on average, so I should know this better, but on average, they give 5, each household receives 5 visits per month. So effectively, it's roughly 3 visits per day.
3 visits. So it's kind of a large incentive scheme, right? So, because you can significantly increase your daily wage. So is that, I mean, does that align with what we know of, with bonus literature and bonuses within companies or things like that?
Yeah, it's actually, so to determine how large it is, you need to consider how long it takes to do, like how much they were working, basically to try to get the fixed wage per hour worked. And because a household visit on average takes 15 minutes, plus obviously you need to move, across, from one visit to the other, we have the calculation. It's like, it's a significant pay, because basically if they work, I don't remember exactly the details, the steepness of the incentive. We actually compare it to some, to existing papers, to other incentive schemes, and it's like I should tell you exactly, but it's not crazy, but it's not low. The incentive scheme. So let me think. If they provide, so conditional on the number of visits, if they don't change the number of visits relative to relative to before the introduction of the scheme, their pay increases by 30%. That's sort of the back of the envelope calculation we did, and we did the pay per hour worked. So it's large. It's definitely large. I don't know whether it's there are different papers that have that are so high powered. Let me actually add an extra piece of information, which actually comes in the next slides, which is actually that these are paid for, that households have to report those visits, and this has a cost. So once you take this into account, the incentive is actually less high powered than it seems. But let me get into that now. So incentives are going to be paid every month by a reputable external organization. And the reason they're paid by a reputable external organization is because the fixed salary was so delayed that we were worried to have the government pay those incentives. So we were working closely with an NGO who made sure the incentive were paid every month. And the incentive were based on a reporting system. So this is the way it works. Each time a health worker provides a visit, she's asked to report that visit by SMS to a toll-free number, in which she has to indicate the date, the service type, the type of service provided, and the contact name of the patient. This is sort of the standard way these incentives work in rural contexts, because you obviously cannot monitor workers more closely, or you don't have an objective or an observable measure of their effort. So very often they rely on self-reports. Now, one worry with self-reports is that you may have over-reporting and that there may be collusion between the supervisors and the worker. That is, they simply agree and simply report a visit that actually didn't take place. Now, to limit this, because we're not interested in the focus on collusion, here we are going to implement frequent back checks. So effectively what we did is that 1/4 of the household who are reported visited are actually called back by enumerators, and we made sure that they were indeed visited. Because of this, and because of the threat of not being able to be in the incentive scheme if they were caught cheating, I'm actually going to show you in a second that over-reporting is literally almost zero in our context. However, one thing that we will observe, which is typical with these self-reported these self-reporting incentive schemes, is that there is going to be a lot of under-reporting in our context. And this is going to be especially the case without worker incentive. That is, when the worker who provides the service is not directly incentivized. And this is going to be very important to think about the cost effectiveness of this scheme. And obviously, the fact that there is a lot of underreporting means that there is a cost in terms of reporting, and I'll come to that in a second. Now, in terms of supervisors are told that they can transfer incentive to workers at their discretion. Yet we're going to see very few side payments. And this is going to be in line with the presence of contractual friction. So supervisors will effectively almost never transfer incentive to the workers informally. This may be because of the presence of poor observability of effort and output. It may also be because of the difficulty of making binding commitments, or because of social norm or preference against redistribution. All this could be reasons for contractual frictions. What we're going to show you is evidence in line with the poor observability of effort and output. We'll show you that contractual frictions are larger when there is poor observability, and side payments are actually lower when there are those contractual frictions, but I'll come to that later on. Now, in terms of fairness, going back to the question that was asked, one thing that will matter, and that matters at this point for me to tell you, is that supervisors were informed about the presence of incentives given to the workers, but not vice versa. What this means is that when a worker provides a service in the supervisor incentive treatment, she does not know that the supervisors gets money for that service. We did that because this mirrors most workplace environment where supervisors know about the pay of their workers, but not vice versa. And this is also going to limit, in a way, negative moral concern of pay inequality. We just thought this was the most natural setting to work in. Importantly, supervisors here do not know workers' actual monthly earning each month. In other words, we didn't tell them each month the number of SMS the worker reported, simply because we didn't have live information on this. And so this is going to limit supervisors' observability of worker effort and output, which is actually common in many workplaces. And again, this is the most natural context to work in. So we believe this setting is sort of the more is the one that mirrors most workplace environments as closely as possible, basically. In terms of data, and feel free to interrupt me, by the way.
I have a question, sort of, I think it's a good place. Maybe you said that, what is the role of the supervisor? So it's providing this information about health, but do they have any power to enforce or suggest how often those health workers should go? Do they have any, power?
Yes. So what they do is that they train and they advise health workers. They can monitor them. They can call them. They can check on them. They cannot fire them, and they do not hire them. So firing and hiring decisions are done by the PHU in charge, who is the head of which basically is another person. So their role is really training and advising.
But for example, I'm thinking about other incentives that are not monetary. For example, you have to go to household that are farther away because I don't like you, things like that.
Yeah, so I'll actually look at targeting in a second. So basically, the supervisor can monitor them. It's obviously very hard to monitor people, in the field, but that's part of their role. Also, when they go on household visits with health workers, the role is to really see also who they target and so forth. They can do many things. I think generally they train and they advise them, and then they can, they're supposed to discuss with them. And in a way, advising is a bit of a black box. Supervising, they can do many things in that. Absolutely, but we'll look at targeting. It's an important one. So just in terms of data, we have data from each layer: supervisors, health workers, and households. I think importantly, from supervisors and health workers, we get data on transfer between them. Health workers are going to be important because they're going to allow us to get measures of how good the supervisor is, how frequent the supervision and the training take place. We also have admin data on the number of visits they self-report by SMS for health workers. And then to measure performance of health workers, we do not rely on SMS sent on self-reports because obviously there is underreporting, and I'll show you this in a second. And so this is not a good measure of actual performance. Instead of relying on the self-reports, we actually survey households. We have a random sample of households which we survey and to whom we ask questions on quantity and quality of the visits provided. So this allows us to know how many visits were provided in the community, what's the quality of those visits, and it's also going to allow us to look at targeting, which household was targeted and which household was not targeted. Let me skip the summary statistics. I guess just FYI, this is a context where most supervisors are men, health workers, 70% are men. And I just want to say this because a number of community health workers program across the world are actually only women. That's not the case here. It's vastly men. Okay. Apologies. Let me just, not even go into the model. I just want to pinpoint a few things about the model that, may help you think about the results. And the few slides I'm presenting you is from actually a simplified version of the model, where we consider only one worker and one supervisor who jointly produce visits Y. So Y is the output. And in the model, there are two periods. In the first period, the supervisors chooses how much effort to provide, that is how much to train and advise workers, and also decide how much to pay the worker for each visit provided by the worker. And how much to pay the worker, we call this S. It's basically a side payment. And because of contractual frictions, each time the health worker receives S, this costs to the supervisor ZS. So Z really captures the contractual friction. In the second period, the worker observes the effort of the supervisors and the transfer and chooses how much effort to provide herself. Efforts can be strategic complements or substitutes. And so we are going to allow output to be a function of both worker effort, but also the multiplication of worker and supervisor's effort. And so here, if gamma is strictly positive, which we are going to find in the structural model, it's a context with effort complementarity. Although if gamma was negative, we allow actually in this model gamma to be potentially negative, which would mean substitutability, but we just don't find this in the data and in the structural model. The incentive paid based on visits is going to be M. So each time a visit is provided, an amount of money M is put on the table. Again, we are not interested in the effect of varying M. This is done by different, other papers. What we're interested in is how the organization decides to share the incentives between the worker and the supervisors in order to maximize visits Y. So the decision of the organization here is going to be to choose the contract P, and more particularly to choose the optimal contract P star, which is effectively going to be to choose how much of the incentive M goes to the worker, P, and how much goes to the supervisor, 1 minus P. And I skip a lot of steps here. I'll skip the utility function, I skip the cost function, everything basically. And the only thing I want to tell you is, and to sort of give you an intuition about, is that the optimal contract P star chosen by the organization is going to be a function of effort complementarity, gamma, and contractual friction, Z. Now, basically, the model, what we will find, and I'll just walk you through without going through all these details, is that if you're in a context with weak effort complementarity, it will not matter whether there are frictions or not. Basically, it's always going to be optimal to give P equal to 1. In other words, everything should be given to the worker. P equal to 1 means everything should be allocated to the worker. This is going to maximize the number of visits, as you can see from these two graphs. This is sort of obvious. It just means that if the supervisor doesn't play a key role in enabling, in allowing workers to perform their tasks effectively, then you should just incentivize the worker. And there are many contexts where effort complementarity are not necessarily very high. Like if you think of, situation where the supervisors take personal decision or only monitors workers, it's less clear that effort complementarity are as strong as in a context where they train health workers, where they train their workers below them. I'm talking about health workers because this is our context, but this is obviously way more general. If you're in a context instead with strong effort complementarity, where really the supervisors and the worker effort complement each other, then it really matters if you're in a context with friction or with no contractual frictions. Now, if there are no contractual frictions, then it doesn't matter how you allocate the incentive. In fact, giving all the money to the supervisors could be weakly optimal. You could tell the supervisors, take all the money, we distribute as you want to the worker, and this would achieve the optimal, the maximum number of visits. Once you have contractual frictions, this is not the case anymore. In fact, if there is strong complementarities and contractual frictions, you're in a world where two-sided incentives are optimal. You're in a world where it's optimal not to give all the incentive to either the bottom or the top layer, but you want to really incentivize both layers. And this is exactly what we find in the data. And so basically, the only thing I want to say here is that our data are going to be consistent with the two-sided incentives being optimal. And this is consistent in this model with the situation with strong effort complementarity and with frictions. It's also consistent with the number of different stories, other stories like fairness concern, and some curvature in the utility functions, but I'll show you later that at least empirically, these two do not seem to be relevant. Any questions at this point?
Okay, can I ask a quick clarification question about the model? So the supervisor is choosing how much to transfer to the worker, and the supervisor maximizes his or her own payment. Is it correct? That's the objective.
That's right.
Right, thank you.
Yeah. Okay, so let me skip the empirical specification. It's straightforward, and let me jump to the results given how much time I have. So basically what we find is that the number of visits is substantially larger in the shared incentive treatment. Now, no matter the treatment you're in, giving an incentive, putting some money per visits provided increases, number of visits in, relative to the control without any money. But sharing the money between the work and the supervisors nearly doubles the boost. And just to be clear here, number of visits is the average number of visits received by a household per month. So you see that it actually boosts by 40% in the worker and in the supervisor incentive treatment, but the boost is substantial, is nearly twice as high in the shared incentive treatment. Now, one worry, and you raised that, is that here the number of visits increases in the shared incentive treatment because health workers may start maybe providing shorter visits, or maybe they may start targeting households who are nearby to save time and money, and they avoid going to further away households who potentially are the poorest and the most deserving. And another story is that maybe maybe health workers compensate for giving more visits by just providing a different type of visits. Maybe they start doing routine visits, which are much shorter, rather than providing pre- and postnatal checks. So there are a number of reasons why you may believe there is a quantity-quality trade-off. And what we see is actually, we don't see any of this trade-off happening. In fact, what we see is that the number of health topics discussed during the visit increases, which is actually consistent with health workers receiving more training by the supervisor, and I'll show you this in a second. We see that the visit length is unchanged. So effectively, they give more visits, the visit length is unchanged, and the content of these visits is improved. We see no differential targeting. We do differential targeting by distance, by wealth, by social ties, and we don't see any differential targeting across treatment. Now, we do see that giving an incentive change who is targeted, but there is no difference in who is targeted across the three incentives. And finally, we observe that actually households have more trust in the health workers and more knowledge about disease prevention in the shared incentive treatment, which again is in line with health workers being able to provide better information about health in these communities. And finally, and I have to go fast on all of this, but we do a lot more here in terms of health outcomes in the paper. We can look at access to pre- and postnatal care, and we can also look at self-reported disease incidence among children in the households. And what you see is that the shared incentive treatment increases pre- and postnatal care, which we measure with the standard 6 WHO indices for pre- and postnatal care. And it also reduces disease incidence, especially for diarrhea. We can also use health facilities data. The nice thing of admin data from health facilities is that these are not self-reported by households. And actually, if you use admin data, you see similar results. You see an increase in the number of women who use the hospital to deliver. You see an increase in prenatal care done at the hospital, which is all again in line with an increase in pre- and postnatal care in those communities with a shared incentive treatment. So this is just to say the shared incentive treatment seems to have improved visits. without a reduction in the quality, and in fact, overall health outcomes seem to have improved in the shared incentive treatment. And the difference are actually precisely estimate for the self-reported data, for the household reported data. And so overall, this seems to be saying output with the two-sided incentives, the shared incentives seems to be better than the one-sided incentive. But one thing which is important to remember here is that payments are based on SMS reports. So one thing is output, but another thing is to estimate the cost of the intervention. And because reporting is going to be costly here and is ex ante not predictable, and reporting is not done by the supervisors, it's done uniquely and only by the health workers, visits are not always going to be reporting in our setting. And just for the insight, part of the problem, which is not actually only a problem in our context, but it's a problem in many other contexts in developing countries, is that phone network is really bad. And actually, phone network is not predictable ex ante. So it works and it doesn't work, it works and it doesn't work. And so it happens that a health worker goes on a visit, and by the time she finishes the visits, she can't actually send the SMS, and eventually she forgets to do that. And so what we see is that reporting rate is low. It's obviously higher when the worker is incentivized for that visit directly, but it's certainly low throughout. And because workers in the worker incentive treatment report more, this makes this treatment the least effective among the three. Basically, the worker incentive treatment leads to the lowest output at the highest cost among the three treatments, while the shared incentive maximizes the number of actual visits. So actual, I mean visits reported by the household per dollar spent. And we do a lot more in terms of cost effectiveness in the paper. So I don't have the time to go into this, but this is to say the fact that incentives are reported because this is a context where effort is obviously hard to measure, makes the worker incentive treatment the least effective. Had effort, actual output being incentivized, we would probably see that in terms of cost effectiveness, the worker incentive treatment would do better, at least in terms of cost effectiveness, although in terms of output, the shared incentive is the one that is expected to do better anyway. So this is really about cost. In terms of the mechanism, just interrupt me if you have any questions. In terms of the mechanism, one thing that we want to try to understand is why are shared incentives so effective, and in line with our model, I'll show you evidence in favor of being in a context where there is both effort complementarity and limited side payments. And let me start with effort complementarity. The first evidence in favor of effort complementarity is that we see that the effort of the supervisor does not increase with the size of the incentive received by the supervisor. So the effort of the supervisor is here measured with a fraction of household visits in which the health worker is accompanied by the supervisor, which is the measure for which we have more variation. And actually what you see is that when the supervisor is paid an incentive, she certainly works more than when she's paid no incentive. But what is interesting is that how much she visits health work, how much she accompanies health worker on visits increases by the same amount in the supervisor and in the shared incentive treatment. And this is despite the fact that how much the supervisors earned in the supervisor incentive treatment is twice as large as in the shared incentive treatment. So there is obviously some indirect incentive they get in the shared incentive treatment, which is in line with effort complementarity. We can also look at situation where you would believe effort complementarity to be stronger. That is, we compare health workers who are inexperienced versus health workers who are experienced. And here you really expect the inexperienced health workers to be more enabled by the supervisor, both because they have no knowledge about health, but also because they really need the supervisors to build trust in the community. And this is exactly what we see. The results of the shared incentive treatment is much stronger in situation where the health workers limited experience. And finally, we can do a mediation analysis to show how worker effort varies with supervisor effort, and you see that it's positive and steep. In terms of contractual frictions, I'm going to be very brief. We basically see very little side payments. We actually asked health worker and supervisors whether they shared money. Very few supervisors do, and literally no health workers share with the supervisors. And the amount they share, even when they do, is on average 1/10 of the incentive they receive from us. So there is very limited payments, side payments. Side payments are especially low in contexts where the supervisors is not even able to rank workers' performance, meaning these are contexts where the supervisors have very little observability of what the worker does. These are typically supervisors who are very far away from the health workers. They have limited knowledge of what they do. And in this setting where there is limited observability of the output and of the supervisor and of the worker effort, we see supervisors literally transferring nothing. So this is in line with contractual friction due to limited effort observability. There are two alternative stories. One is one of basically health workers being, health workers and supervisors being pissed off by the one-sided incentive, but loving the two-sided incentives because it's more fair. But this isn't likely to happen because first, health workers are actually not aware of supervisors' incentives, and at Enland they didn't learn about it. We also have data on worker satisfaction, and actually we also have data on the sense to which they perceive the incentive as being fair, and we don't see differences across treatment. And then we see supervisors' effort being higher when the worker gets an incentive than when they don't. So all this is sort of saying this is unlikely to happen, to be explaining, why the shared incentive really is the best. The final story is one of some sharp discontinuity in the utility or in the cost function. We do non-parametrically, we look at the effect of the treatments by different measures of marginal utility and cost of effort, and we don't see any discontinuities. I'm going to skip this because this is sort of a crazy story. So happy to talk about this, but it doesn't seem to explain the results. So I really don't think I have much time. So let me just say, just one couple of things on the structural model. We structurally estimate our model, and I think what really comes out of the model is that first, the estimated model precisely reproduced the key finding, which is reassuring. But especially our model allows us to estimate the gamma and the z parameters. And we find that complementarity raises the return to worker effort by 82% relative to a situation where gamma is 0. And we also find that side payments are 45% more costly due to contractual frictions. So, these are two numbers that seem to suggest that our context has indeed strong effort complementarity and contractual friction. But it's really hard to know if this is large or not relative to other contexts. So we have a model. In the model, we estimate what would change if the context was different. Before we do that, we estimate the optimal contract in our setting, which we estimate to be 54%. So actually, in our setting, we estimate that the optimal contract is one where you give 54% to the worker and the rest to the supervisor. So this is quite similar, quite close to the shared incentive treatment. And we can show how the optimal P star, the optimal share of the allocation changes as effort complementarity increases. And obviously, if you're in a context with really low effort complementarity, as we showed before, you should give everything to the worker. If you're in a context with more effort complementarity than in our setting, you should give more to the supervisor. And actually, this is not an obvious result. At some point here, it's going to plateau. But we are sort of, we are at this level of complementarity where the gamma is 7.9. Again, it's really hard to know if this is higher or low. We can do a simulation of whether it would have been better to tie incentives to effort directly, that is pay workers for how many times they attempt a visit, and pay supervisors for how many times they train the workers. So really incentivizing effort directly rather than incentivizing joint output. And we show that even if effort was fully observable, which obviously isn't the case in our context, it would still be better to incentivize based on joint output in a situation with effort complementarity. And this is because incentivizing based on joint output really helps internalize the positive effect that that a worker effort has on the other layer. So when you're in a context with effort complementarity, it seems to be optimal to incentivize based on joint output rather than based on effort directly on the input. So let me conclude, and then we can have a discussion. And if you have any questions, we can discuss. I just want to say one thing here. Before we released the results of this experiment, we did this thing we invited social scientists to forecast our treatment on the social science prediction platform. And what we find is that most people who want to in this platform, which are PhD in economics or faculty in economics, mostly in economics, they typically predicted the worker incentives to work better than the supervisor incentive or the shared incentive. And roughly 18% said any incentive would work equally, which means that they were probably internalizing that there would be no contractual frictions. The fact that the worker incentive was so popular among economists is probably not something so surprising if you think that most of the existing evidence on incentives actually shows that worker incentive, incentivizing frontline workers, is effective. So there are many papers that show that giving money to teachers, health workers, tax collectors, sales associates improve their performance. What we try to argue in this paper is that if you're in a large organization with complementarities and friction, worker incentive certainly does best than nothing, but they are less cost effective than supervisors and then shared incentive. In fact, the boost in output is 61% lower than the boost in output you get with the shared incentives and at a lower cost. So shared incentive may be less effective, certainly very effective in our context. One thing to keep in mind is that they may be less effective in organizations where the production function exhibit less effort complementarity, as I showed you before in the graph in the structural model. For instance, if you're in a context where the supervisor's role is limited to monitoring, distributing tasks, or making personnel decisions, effort complementarity may not be that strong. And then at that point, incentivizing only the frontline worker, as it's typically done in many developing contexts, may be optimal. Overall, this suggests that organizations should calibrate incentive based on the effort complementarity, and especially in a situation where there is contractual frictions. Because again, if there was no contractual friction, it wouldn't matter how you would allocate the incentive in the first place. I will conclude here.
Great. Thank you so much, Erika. I guess
apologies for I'm seeing I'm 4 minutes late. Apologies for that.
No, I think that's fine. We also started a couple of minutes late. Yeah, so thank you very much. Let me turn off the recording. And in the meanwhile, if people have questions, I guess you can just unmute yourself and get started.